So we stand between you and lunch, so we'll try and keep things moving. And it's also good that Dr. Sweater sort of introduced the current trial, so you have a sense of what's going on. And I think some of you are probably already familiar with PHP. My task is to sort of introduce the concept of this and then talk about some of the data that already exist. So the question I'll try to at least introduce for you are why would you consider liver perfusion as a treatment? How is it done? What's the technical aspects of this? What would you expect if you were going to have it done? And then to talk about some of the data that exist from a prior phase 3 trial and some of the preliminary stuff for what's going on more recently. So obviously you know that the liver is a big site of concern for uveal melanomas, and many of the therapies for metastatic disease are directed toward the liver, and whether it's resection, whether it's therapies that are targeted, thermal therapies, cryotherapy, Y90, those sorts of things. But we talk about perfusion of the liver because the liver is very conducive to perfusing the entire liver, isolating the vascular supply of the liver, and being able to really direct therapy to it just anatomically. So you can see, all of the blood that's draining out of the liver drains into a fairly narrow segment of the main vein that's back behind the IVC. And similarly, the blood that's coming into the liver comes through a fairly well-defined set of arteries. And so the majority of the blood flow that goes into the tumor comes from the hepatic artery, which is relatively easily accessible. So you can really direct the drug to the tumors that way. And by isolating the blood flow, the vascular supply, you can keep that treatment confined to the liver. So the side effects that you think of with treatment of chemotherapy, you can be spared most of the exposure of the body if the blood is kept away. And as it's the most common site, the predominant site, the life-limiting site of metastatic disease for uveal melanomas, it's a great target. All right, now I can move around if I need to. So how is this isolated hepatic perfusion done? As you saw, there's a fairly long list of participants in these procedures, and for the physicians that are involved, it's a circus in some ways to get it all put together. But you can see that this is just for the procedure itself. You have a patient here looking down from above on the radiology table. You have an interventional radiologist like Dr. Hwong. You have typically a surgeon like me that's both involved in the procedure. You've got techs to help with the equipment. You have a perfusionist to help with the pumps and the filters. You have an anesthesiologist because the procedure is done under anesthesia. Nurses to help with the chemotherapy. Research personnel to help with the trial part of it. And then outside of this, you have a medical oncologist that's involved as well. And so it's everybody who has all your best interests at heart working together to try and get this treatment done. And so what happens, it's all done now, used to be done with an open procedure, it's now done percutaneously. So it's a radiology-based procedure. And what's involved is the insertion of catheters in 3 sites. So just the same kind of catheter that people have for heart catheterizations and things like that. There's a catheter that's put into one of the femoral arteries, a larger Delcat-specific catheter that's put in through a femoral vein, and then a return line above that brings blood back into the jugular vein. And so the chemotherapy is given through the artery, and then that perfuses the entire liver. And then that blood that's in the liver gets isolated between that specialized catheter and is drained out so the blood that contains the chemotherapy is drained out. It passes through these activated carbon filters that are outside of the body. That removes the vast majority of the chemotherapy, and then the blood that's been cleansed of the chemotherapy is re-given back through that line in the jugular vein. And so you can give much, much higher doses of chemo. So we don't generally think of chemotherapy as being particularly great for melanoma. But this enables you to give much, much higher doses of chemotherapy than you could possibly give to the whole body and get it to a level where the melanoma will be more likely to respond. So these are just pictures of the angiograms that are done when the catheters are being inserted into the liver. This is the blood vessels that go to the intestines, basically, and so you find these to make sure there aren't any side branches that go to the liver. And then this is the artery that you're actually after, and this goes out to the spleen, it goes to the stomach, and then other parts of the intestine. But here, these branches are the ones that are going, is that on there? So this is going to the spleen, this is going to the stomach, this is going to parts of the intestine, but these are the branches that are going to the liver. So you get the catheter positioned in the right position. Sometimes you'll block off these arteries so that when you give the chemotherapy, it all goes where you want it to. Then the specialized part of this, this dual balloon catheter, that's the one that goes in the vein behind the liver. And it has, as you see, 2 balloons on it. Essentially they go above and below that part of the vein where all of the blood from the liver is coming back in. I don't know if you can see them, but there are little holes in this part of the catheter that's in between. And so all of that chemotherapy-laden blood that's coming out of the liver passes into those little holes and then is drained out through the catheter to get to those filters outside. So you'll position those balloons. That's actually the heart above, the diaphragm there, and then the balloons showing where all that blood comes in. And that's what the x-ray of that looks like. So the upper balloon and the diaphragm's up here, the lower balloon. So that's that segment of the big vein behind. And then these are the veins that are draining the chemotherapy, the hepatic veins draining the chemotherapy out of the liver. And so when you have this system of isolation, what you're able to do is get a big differential between what the body sees and what the liver sees. So this is pharmacokinetics is just showing how much, what the concentration of the drug is in the blood. So this is what the liver sees. This is what comes out from the filters. And then this is what the body sees. So that kind of differential allows you to get up to concentrations that the melanoma actually will be able to respond to. And so this was put through a large randomized clinical trial, prospective clinical trial, where patients were assigned to get this treatment or to get an alternative treatment. And then there was a comparison. And the comparison that they were looking for in the trial was hepatic progression-free survival, how long it took for tumors to begin to grow in the liver, which is really the target of the therapy. And the trial came out exactly as it was designed to come out. In the upper left, that's the primary endpoint, this comparison of how long it takes for the tumor to progress in the liver. And there's a big extension of that. So it's about 245 or so days in the patients that got the PHP, and basically at the first scan for the patients that didn't get PHP. And so there was this big difference. It met the planned endpoint of the trial. This is for progression overall, and since that's different as well, it just shows that the liver is really the primary target for therapy. But overall survival, you see, was not significantly different, and we'll explore a little bit why that is in a second. But that was not actually the goal of the study, was not to show that. Because what happens in the study is, in this study, was that people could cross over. So if you got into the alternative care arm and you got assigned to some other therapy, as soon as they saw that you were progressing in your liver, you could switch over and get the perfusion at that point. And for the people that were in that alternative arm, the ones that crossed over did just as well as the patients that were in that arm originally. So you wouldn't really expect to see that there would be a big difference in survival based on the arm of the trial. And this is just an example of one of my patients from the trial. And I've outlined the sites on his MRI of where his tumors were when he initially came to us. And he got assigned to the alternative care arm. He got chemotherapy and it didn't work, and his tumors progressed. And then he crossed over, and so he ended up getting perfusion then subsequently and had a great response, which lasted for a good long time for him. And so he didn't suffer as a result of being assigned to the alternative care arm, because he went on to get the same therapy. So you can see with this sort of thing why there wouldn't really be a difference in the trial for overall survival. This is what's called a waterfall plot. This is for each bar on the plot represents a patient, and whether their tumors got bigger, the line goes up. If their tumors got smaller, the lines go down. And so the PHP patients are on the top. The ones that were in the alternative care group are on the bottom. And so you can see how much better they did when they got perfusion than when they got the alternative care treatment. More recently, as you know, as I mentioned, John Zager, who is at the Moffitt Cancer Center in Tampa, has been doing these perfusions as well, and really the results are very similar in terms of responses. These are the patients that he's treated more recently, most of whom had ocular or uveal melanomas. This is a comparison that they've done also with those patients from Moffitt, looking at other types of therapy that these patients may have gotten. The green line there are the PHP patients, and then either chemoembolization or yttrium-90 are the blue and red. And this is about hepatic progression as well. And I think the difference that's there may be related to the fact that you're treating the whole liver rather than selected treatments. Doesn't necessarily mean that that'll translate to overall survival differences, but an interesting difference nonetheless. The toxicity of the treatment over the period of therapy is mainly the effect of the chemotherapy that slips through and gets into the rest of the body. So it's hematologic side effects, anemia, low white blood cell counts, low platelet counts. They have not had lasting trouble with the patients that have been treated with the newer generation of filters that Dr. Zager is using. You have to be somewhat fit to have this treatment, and it's mainly because there's hemodynamic blood pressure type changes that happen during the treatment. So when you're messing around with how the blood flows in the body, that will cause some drop in blood pressure initially. The other thing that we don't have a full explanation for is when these filters are engaged and the blood is going through them, the blood pressure drops again for a few minutes, and then with medication and just with time, it comes back up again. So you don't want to have a very fragile heart or something like that to have this done, but older patients have tolerated it just fine, and this does seem to be self-limited during the therapy. This is just an example of a patient from the original series in terms of what happens to the blood counts. And so all of the blood counts of platelets here and the white blood cells fall over the few initial week or two after the procedure and then come back up again. One thing that has changed since this was done is that the filters have been improved. And so when you look here, these sort of bottom out at fairly low numbers. So platelets of 20 to 30,000 is pretty low. White blood cell count of 1 or 2,000 is fairly low. But the current generation filter seems to remove more chemotherapy than was the case here. This is plots of some of Dr. Zager's patients in terms of their white blood cell counts, and you can see for these patients who've received multiple perfusions, they never have fallen below that 2,000 level, which is pretty good. Similarly for platelets, they've stayed for all these patients over 100,000, which is a perfectly good number of platelets. So the filters seem to be improved based upon new formulation for the activated carbon particles that are in there. When you experiment with these on the tabletop, they do extract more of the drug more reliably. And now the therapy is actually approved in Europe, and they've looked at pharmacokinetically how much of the drug is actually removed during this process, and it's up significantly from where it was in the prior trial. And so the experience has been that these hematologic side effects are less significant than they were in the earlier generation. And when they compare the older generation filters to the newer generation filters in terms of these side effects, the adverse events in the trial, they've improved. It's not a side-by-side comparison, but it looks very encouraging in terms of patients' ability to tolerate this therapy well. So I think that brings us sort of up to date in terms of a lot of the data that are available for PHP. And I will turn the floor over to Dr. Hwang, who is, shall I do the introduction? She's Associate Professor of Radiology at Stanford and is the Associate Director of their residency program and is the radiology lead for the trial as it's being conducted at Stanford. Oh, there you are.
Thank you.
Do you want this?
I appear out of nowhere. So to finish the discussion about percutaneous hepatic perfusion is Gloria Hwang, MD. Gloria is a clinical associate professor of radiology and associate program director for Stanford Radiology's residency program. And she serves as the IR lead at Stanford Healthcare for the FOCUS trial for hepatic dominant ocular melanoma. Welcome, Dr. Hwang.
Thank you. How many of you know what an interventional radiologist is? Excellent. How many of you, and you've had the same number of people then have been treated or have intersected medically with interventional radiology? Since the minority of the hands went up, I'm just going to first give a quick overview of who I am and my group, what my group is and why we are involved in your care. So interventional radiology is the specialty of minimally invasive image-guided interventions. It means that rather than make incisions in your body to achieve what we need to achieve, we use X-rays and CTs and ultrasounds to get into where we need to go, and at the end of your procedure, all you see is a Band-Aid where we went into your body. No big incisions that are very painful, and very, very, very small scars, if any scars, at the end of the day. And we are one of a really big team of people who would be working with you to fight your cancer if you enrolled in the FOCUS trial. And I just, by way of background, they told me I'm supposed to talk to you about the phase 3 trial, which is what I'm participating in right now. But I just wanted to give you, I guess, a background of why I participate in this trial, because I do a lot of cancer work. Most of my patients have other kinds of cancers, such as hepatocellular carcinoma, sarcomas, colorectal cancer. And so my goal as a clinical interventional radiologist is to do treatments that help people prolong their lives and improve their quality of life. I actually don't believe in research for research's sake, and so I have a pretty high threshold for participating in research to manage patients. And so Sunil Reddy, who does not know that I used his picture in this talk, and he would be here today. He reached out to me because he had a conflict, and I just learned from Hwong out there that conflict is he's getting married today. So Dr. Reddy reached out to our group saying, hey, would you like to participate in this trial to treat ocular melanoma patients? And I know that metastatic ocular melanoma is a really tough nut to crack, and we're working on it. And I said, well, tell me about this trial, because I knew it was using Delcath. I know that Delcath's products had been around a long time. I had heard that people were, back in the day, were working at the King's. I hadn't heard much recently. It's like, why is it worth it for us to do this trial? And then he showed the same data that Dr. Faries has just shown you, showing those survival curves, showing the improvement in time to progression. He said, look, you guys are doing chemoembolizations, which means injecting chemo into people's livers with something that helps keep it retained in the liver for long enough to try to kill the cancer. Radioembolization, which means injecting these really radioactive particles into people's livers. And ablations, which means sticking needles into patients' bodies and freezing or burning tumors. He's saying, you're doing all those things. I don't think it works as well as Delcath, but we don't know. And we need to do a study to see what works better. I do have this data from previous studies that shows that this system may do better than what we currently have to offer either systemically or interventionally. I can't do this study without interventional radiology. And so knowing that and talking to my partners who also do interventional oncology, I was sold. I was like, this is not research for research's sake. This is actually very meaningful work. So it's only fair for me to put my picture here because I put Dr. Reddy's picture here too. And so I would give him the lion's share of credit because he did a lot of work, because not only did he get me and my group in on this project, but he recruited all those other pieces that you need to get to make this happen. So we have a surgical oncologist, we have anesthesiology leads who will help make sure that we have a team that knows how to manage things like blood pressure and blood products during and after the procedure. He got ICU, the intensive care unit involved, since they'll be helping manage blood pressure, blood products after the procedure. Perfusionists, the people who will be in there working the filter, he has them, pharmacy, so that they can deliver the drug in a timely fashion. All those people I've met their representatives, and they are great, and we are ready to go. So whenever whenever a patient comes, we have a coordinated plan on how to go about doing this procedure, because it does take a lot of coordination. This is just, because I know it's scary to see new things. This is the kind of room that we use. This is one of our IR rooms. It is not a scary place. It's an X-ray tube, a Tempur-Pedic, not very soft, mattress on the table, various catheters and equipment, and I don't have a picture of the wonderful staff that we have that help work the room in addition to the other people that were described. So the actual trial itself and what we're trying to study, this is a phase 3 trial for hepatic dominant ocular melanoma, meaning this is when the cancer goes to the liver, and we think that the liver, the cancer in the liver is the most dangerous thing that you have. So what this trial does is we have intention to treat. Everyone's going to get a treatment, and there's a 1-to-1 randomization between getting the melphalan hepatic perfusion versus best alternative care. And at Stanford, best alternative care would be, I think, number 1, we've decided chemoembolization, which could be repeated, would be the first choice. Immunotherapy would be other choices, and then we have the systemic chemotherapy as another choice, and those are all options, and I guess we can use any option. We would discuss what would be the best option for the patient, and what we're looking for are various endpoints, the primary being overall survival. We want to know, are we extending lives, how far, and is one treatment better than the other. Secondary endpoints, progression-free survival, objective response rate, like what you saw on those other slides. We also wanted to make sure that what we're doing is safe, that the pharmacokinetics, meaning that the amount of drug in the patient's body is safe also, and that we're not adversely affecting quality of life, and hopefully are improving quality of life in the long run. So this is, you'll probably, if you enroll in a trial, will see these same questions printed on a sheet of paper. These are just in lay terms, frequently asked questions about the trial. When did we start? January 2016. How long do I participate? About a year, and then we'll keep checking in on you. We're aiming to have 240 participants. Number of hospitals are participating, and again, we're comparing this chemosat technology with best alternative care, and we're measuring tumor response to treatments, and also how well a patient does after getting treatments. We've talked about the alternatives, and we are following up the cancer growth with scans, either CTs or MRIs, pretty frequent. You're going to have a team. One of the good things about being in the clinical trial is you get a lot of attention. So good or bad, you get a lot of attention from us. You're going to get a lot of scans. You're going to have a lot of clinic visits. That's part of being a trial, but it's good because it means someone is monitoring you very closely. If you get the Delcath treatment, then you're going to get the treatment every 6 to 8 weeks for up to 6 treatments. So we'll become very familiar with each other if that's the arm that you're randomized to. You would expect to be in the hospital. You come in the night before, get hydrated, get your IVs, get everything set. After the procedure, you're going to go to the ICU for monitoring to make sure your blood pressure is well managed, tightly managed, and then when you exit the ICU will just depend on the blood pressure management and how you're doing clinically. Some people go home in 1 day, many people go home within 3 days. So and then if you get randomized to the best alternative treatment, then we'll bring you in. Many of our treatments are either same day or overnight stay for chemoembolization. Some people stay overnight, some people go home the same day. We would do it iteratively also. And if you get the immunotherapy, you would come every 3 weeks for that treatment. You get blood work, you get your scans, we follow you through the whole process. There are certain qualifications that I totally don't expect you to remember because it's a lot of stuff, and it's our job to make sure that you meet the qualifications for the study, including weight, the amount of tumor in the liver, where it's spread, other therapies that you've had, how healthy you are in general. We cannot treat people with cirrhosis. Cirrhosis is when your liver is so diseased that it's very scarred down. Just because any people with cirrhosis, the liver function isn't as good, and we don't want to over-compromise liver function. Likewise, heart and lung problems are something that if that's already happening, we don't want to stress people who already have significant heart or lung problems or bleeding problems because of the blood count variation around the time of the procedure, cancer to the brain because of the bleeding risk there, uncontrolled diabetes, and also pregnancy. So the number of sites. Stanford's one of them, and also in Europe. And you'll be able to find this information on websites too, but this is our contact information if you would like to get more information about enrolling in the study. And to be fair, this is Dr. Faries' contact information too. And here's the website for the clinical trial. Thank you very much.
Got a few questions before lunch.
I've got a question for both the doctors. There's a lot of chatter in the online support groups for ocular melanoma about this study. And one of the concerns is, and first speaker alluded to it, is if you get randomized to the not Delcath trial, you basically just want to drop out. And some of those people are actually going overseas to have treatment done. And I'm wondering what your thoughts are on the treatment, and is there any effort being made to make the non-Delcath arm more attractive for ocular melanoma patients?
Yes. So the problem that you face is to the non-Delcath arm is what would you put in that arm? And in the first trial, it was you could pick anything at all because at that point there was nothing but really a signal of great benefit. And so these 4 choices that were laid out were essentially mandated by the FDA. So you got to pick a limited number of things, and you have to order them in your order of preference, and that's the only way that they would let the trial go forward. And there's been a lot of controversy in the last several years as therapies in general have gotten better about what should be required of a clinical trial to get the thing approved. And so in cutaneous melanoma, with things like BRAF and MEK inhibitors, there are these New York Times stories and exposés about, the cousins. One was randomized to the control and one was randomized to the treatment and how much of a difference it made. And so there's been some question as to whether the old-fashioned randomized trial with no crossover and survival as the endpoint is the only way to have these trials work. But the ultimate determinant of that is the FDA. So Delcath can only do, in terms of designing the trial, can only do what the FDA will let them do. In the prior phase 3 trial that allowed crossover, which made it much more appealing, the company and the FDA had sat down and they had agreed before the trial started, well, this is what our endpoint's going to be, and we're going to allow crossover, and if the trial's positive, we're going to approve your thing. Well, then they changed their mind after the trial was done. because the trial worked out exactly as it was planned to work out. So there's been some effort to try to work with the FDA, I think, to see if there's something that can be done to rearrange this trial, but it's ultimately up to them. And so if any of you reach out to the FDA, if any of you reach out to your representatives in Congress and have them reach out to the FDA, then there may be a way. In my mind, if this trial was conducted and worked out just like the first trial did, that would be enough evidence for me that the treatment should be approved. And in fact, the first trial was enough to get it approved in Europe, but we're limited in terms of what we're permitted to do. The ultimate goal of the trial is to get it approved so that people don't have to go through a trial to get it. But until there's enough proof to satisfy the FDA, we have to try and get the trial done.
Do you have any update on the number of people that are in the trial yet, in total?
I think it's in the 30s.
34.
What is it?
34.
34.
Is that the U.S. undertime? It's everybody, so that's 34 out of 240.
So there's quite a distance in terms of what needs to be done to have enough people in the trial to get an endpoint that can be interpreted.
Oh, so,
Yeah, total.
people from Europe come here.
No, it's open in sites in Europe.
Thank you. You know, we're in the Mets group, so needing to enter a clinical trial, but I want to be a woman of integrity, but if I didn't get Delcath, you know, I don't want to enroll in this trial for a coin toss and then tell you that I'm not going to do the other arm. I would rather pursue something else, a different clinical trial, than to use the time and effort that, you know, Stanford is doing for people if I didn't get it, because I know the case that we are in right now. Delcath is our best hope. So, you know, what I'm asking you is, do we go in and hoping for the, you know, I mean, we're just trusting the Lord and all this for the coin toss, and if we don't get the Delcath arm, not doing it, I want to do the right thing. But if we didn't get it, I'd rather not enroll than have the chance of not getting and tell you we're not going to do it if it's not Delcath.
Yeah,
So
so
I know.
one thing to remember, I guess, if you're contemplating entering the trial, is that what you sign when you enter the trial is a consent form, not a contract. So it doesn't obligate you, really, to do anything. But I will say that, so Stanford's first choice in their alternate therapy is chemoembolization. That's not without benefit. We suspect that maybe the perfusion is going to be better, but the response rates for the lesions that are targeted are fairly high. And so I wouldn't think of it, you're certainly not getting nothing.
Right.
If you get one of the immune therapies, the response rates are not zero, and if you have a response, they may be durable. And so it's you're not sort of abandoning hope
Right.
if you get the alternative care arm. And then, you know, if you get the alternative care and you're not responding as well to it as we hope you would, then you can find something else.
Okay. All right. And we did write the FDA. Okay, so.
Yeah.
I have a question about the trial. So are all the trial sites using chemoembolism as their alternative, and is your immunotherapy, it's not immunoembolism, it's just plain immunotherapy with drugs?
Right, it's each site, it's the same list of 4 choices. Each site gets to prioritize them of what order they would hypothetically pick. And then for each individual patient that's in the study, they can choose among those 4 what they think is the best for that particular patient, no matter how they rank them beforehand.
Is immunoembolism an option or no? So your immunotherapy is like the plain immunotherapy?
It's the
Traditional
Yeah,
immunotherapy.
so it's the most up-to-date modern cutaneous melanoma immunotherapy,
Oh.
but not the immunoembo.
I have a question. My husband was in the trial, but he was in the, not the Delcath branch, and now he's been released from the trial because of progression of disease. Isolated to the liver, less than 20%, and he'd be an ideal candidate for Delcath. Is there any effort on Delcath's part to plead with the FDA? We're pleading with the FDA, but is Delcath doing anything? Or I know you said speak to your local Congress people, but I'd like somehow us to be given tools to help us maybe make it happen. Otherwise, I know a handful of people that are flying and paying out of pocket in England. Why can't we, petition them to do that here and at least pay out of pocket here and stay with our own teams that we love?
There.
So I know it's an emotional topic, so I don't mean to, but it's
very emotional.
So my name is Jennifer, I'm the CEO of Dropbox. We have been working very closely with the FDA. The biggest issue, Okay, sorry about that. The biggest issue that we have is, I think, what Dr. Faries outlined in the beginning, which is in order for the FDA to make the determination that this is better than the others, they're basically saying you can't technically cross over. And that, in essence, what you're saying would be a crossover. So you've gone on the one side and it didn't work. We have continued this conversation. We've actually had discussions with the FDA about, can we somehow do some type of crossover? I will not abandon this topic, I guarantee you that, because of why I'm here, right? Which is to give all of you options. Is this the right therapy for everybody? No. But I want to make sure that people have options. What I would implore you is to do exactly what Dr. Faries said. Write to the FDA. We have contact information. We can certainly give that to you. Reach out to your congressman, your congresswoman. Implore them. One of the things is that, we certainly know that tumors of great size, breast cancer, that there's a lot of noise behind that. This is a small group, and I think it makes it difficult because we have to be even more vocal, than ever, and it's a collective. So you have my guarantee that we will not stop. We will continue to push the FDA, but we need help.
What is the best case scenario for this trial phase to be approved and this be available to the market?
It'll be most dependent on how quickly the trial gathers enough patients, and if it is able to pick up steam, so there are more centers that are getting open, and so the number of patients that come in may increase over time. Certainly, if the eligibility gets more attractive, that may help as well. But it'll be years, I would think, at a minimum before the trial's finished, the follow-up is enough, the endpoints are analyzed. Not a lot of years, but probably out beyond a year at least.
Thank you.
I was just wondering, what are the costs of the trial? And then the other question is there a way the trial could be redesigned so you could have 3 people in versus 1 in the, 3 to 1? 3 people get, I'm just wondering, because I know there are some trials that are set up that way, that 3 to 1 or some, so it's a better chance that people get the preferred treatment.
That actually plays with the numbers. That's statistics. And believe it or not, we did look at that, but we would need more people, oddly enough. So that's why it's 1-to-1.
Yeah, and in terms of the cost, which is essentially true for all clinical trials, any parts of the care that are given that are standard of care are paid for by your insurance, those sorts of things. And anything that's done specifically for the trial is paid for by the trial. So you wouldn't have to worry about paying for the perfusion and things like that.
To add to that, so are the patients paying for the MRIs and CT scans, or is that part of the trial?
So all part of the trial. So a lot of scans kind of fall under standard of care.
Right.
And so then they'd go to your insurance or Medicare or whatever. And if they're not covered they don't fall under that, because there are more of them than would normally done, things like that, then the trial pays for them.
I have a quick question over here. Being that I'm a medical patient, I'm restricted to my state of Missouri. Saigon is the clinic, research facility out of St. Louis, Washington University. Is the trial out there? So I mean, it's a 5-hour drive for me to go there. Yes. You know, yes. And who would I contact there?
Right there? Right there.
Okay. I can't see you.
We will share these, assuming it's okay, we'll have these slides available afterwards.
Okay.
So you can see everywhere that it's being offered.